Perfect. Well, thanks, Jeff. You know, I'm very excited about what's going on here in Iowa. I think we're really progressive with regards to significant disabling disorder. I think, like Jeff said, I think it's a marathon, but I think we've become so much more aware of the significant consequences of mild traumatic brain injury and chronic encephalopathy that I think we can provide a lot of leadership and camaraderie with each other. I want to thank the Brain Injury Alliance of our state for formulating the Iowa Concussion Consortium, which is a large group of individuals and organizations that support REAP, which Dr. Karen McAvoy is going to be extensively talking about after I'm done providing an overview of caring for kids with concussions. Before getting started, one of our therapists said, because I was talking in Iowa at University of Iowa a couple of nights ago on a different topic, she said, well, how do you do all these presentations? And I honestly said, well, all these presentations are basically put together for me. And so I'm kind of the spokesman for the group, and I want to acknowledge the concussion team at ChildServe that's been very instrumental in developing the program and in carrying out the evaluations and providing the management. With Laura, Carrie, Ashley, Jill, Matt, Hannah, and Rayanne, and the people from Ames. Can you just stand up real quickly? So those are the people that are really behind this presentation. So what I want to do today is fulfill 6 objectives, and those are to identify the characteristics of concussions, to highlight their significance, to outline the systematic management of concussions at this point in time, and then to discuss evaluation and treatment of these concussions, and then to provide some specific details regarding returning to learn and returning to returning to work and returning to sports protocols. So a concussion is a brain injury. It's a mild brain injury, and it is a clinical syndrome that's characterized by immediate and a transient alteration in brain function, including an possible alteration in level of consciousness, which is due to forces and trauma that overwhelm the cellular system. As Jeff alluded to, thanks. Oh, wow.
There you go.
That's better. Hype up, everybody. As Jeff alluded to, the New York Times published an article that was of a study from Boston University regarding the presence of a chronic traumatic encephalopathy, and I think it really brought it to the forefront of the American public. And it's interesting, I subsequently cited that article on a Facebook page. And what was very interesting to me is I almost got 0 response to that post. And it's very interesting to me because none of my professional peers, none of my fellow physiatrists even responded to that post. And I was kind of shocked by that. But I think this is what's going on. I think we now have a struggle, and I think parents are going to really be struggling, and I think parents in Iowa are really going to be struggling about how to deal with football. That's what it's coming down to. What is in the best interest? I love football, says the parent, myself also, but I want to make sure that I'm protecting my kid. So now they've got the 49-51 decision to make. Do I have my child participate in football? When do I have them start to participate? Or am I causing possible irreversible damage to my child by having him engage in that? That's the essence of what we're going to be dealing with in the next several years. So chronic traumatic encephalopathy is a neurodegenerative disease. It's due to related blows to the head, and it results in a dementia-like signs and symptoms. So Tyler Sash, who's one of our University of Michigan, I'm from the University of Michigan, University of Iowa Hawkeyes that sadly passed away, was part of this study. And I won't go into great details regarding this, but it points out that there appears to be a significant association between repeated blows to the head and the development of this neurodegenerative disease. So what we're focusing on and what we want to promote is an evidence-based approach to managing concussions. At this point, there are a few key organizations that have been focusing on this, but I think it's important for us to keep in mind that we're just at the infancy of really appreciating the long-term consequences of a mild traumatic brain injury. One of the key documents that's used is this Berlin consensus statement, and it focuses on best practices in 11 major areas. Coming out of the Berlin conference was a number of systematic reviews on pertinent questions. And what I'm finding is that the more that we're getting into this area, we're beginning to better appreciate what the key challenges in the questions are. For example, what our team is now focusing more extensively on is how do we manage headaches. Headaches seem to be showing up in a lot of these kids, and fortunately for most of them they'll resolve over a fairly short period of time, but in a few cases they're persisting. So we've got to identify what the evidence out there is saying about headaches so that we're using an evidence-based approach. Another example may be dizziness. So as we're getting farther and farther along into this field and really focusing on it, we're beginning to see what the key impairments are that are impacting the child and the adolescent's ability to participate in school and in their academics. So we want to use an evidence-based approach. Another group that's been focusing on this area is the Pediatric Mild Traumatic Brain Injury Guideline Work Group. And that's a group of experts that have reviewed the literature. They've summarized that literature, and they've come up with specific recommendations regarding the diagnosis, the prognosis, and the management of a mild traumatic brain injury. So an updated definition of a sports-related traumatic brain injury is that it refers to a biomechanical phenomena where the forces are overwhelming the brain cells. It can be a direct blow to the head, face, neck, or elsewhere. So I think that this is an important point. And early on in my studying this area, I unconsciously thought that the injury had to be a direct blow to the head. And now I've subsequently come to appreciate it can be a blow to the chest that then ends up resulting in forces that impact the brain. So it doesn't just have to be a direct blow to the head. These forces may result in neuropathological changes, and they end up being functional changes rather than structural changes. So what I mean by that is that only in about 10% of the CTs that are done end up showing structural changes, so changes in the anatomy. But 90% of the CTs end up as being unremarkable, even though the child's clinically presenting with signs and symptoms that are consistent with the concussion. So the other key thing that I want to point out here is that there are some of us out there that think that the concussion has to 100% be associated with a loss of consciousness, and that is not necessarily the case. So what ends up happening essentially here is that there is a force that either direct or indirect that impacts the head, and if it's a direct force, it results in a coup injury right to where the force is, and then because the brain is housed in this liquid, it then rotates and ends up causing a counter coup injury as well. So you can end up having elements of coup, counter coup, and rotation. And that ends up impacting the cells of the brain or the neurons of the brain. So a concussion results in a metabolic issue. It's a metabolic issue. It results in the cells not having enough energy to function. And I won't go into the details of this, but the issue is, in a brain injury, is do you get to the point where you overwhelm the cells and they end up causing cell death, permanent cell death, or do you get to the edge where there's significant swelling and edema, but still the cell is intact, but it's just not getting adequate amount of energy at that point. So it's a metabolic issue. And I think that has significant ramifications when we talk a little bit later down with this lecture, is that you can have, the point is that you can have a resolution of the clinical symptoms, but still have a metabolic, an altered metabolic process that's going on, which can set up the individual for a second impact syndrome, which I'll talk about in just a second. So let's talk a little bit about that epidemiology. And what I want to just highlight here is that in the kids that are younger than 10 years of age, and the boys and the girls that are under 10 years of age, many of these injuries will take place on the playground. So there has been some movement, and this is has come before the big push on concussions, has been movement in altering the environment of the playgrounds. So when many of us grew up, we were playing on asphalt playgrounds or cement playgrounds. So now we've moved to wood chips or to softer surfaces. And then in the kids that are age 10 to 19, they tend to be related to bicycling in both girls and boys. And in the case of boys, it's football, and in the case of girls, it is soccer. This next slide I find interesting in that the football makes sense, easy to understand. Girls soccer can also be easy to understand, but also higher on this list is cheerleading as well. So the challenging thing, at least at this point, in August 2015, is that we don't have a laboratory means of diagnosing a concussion. So when you make diagnosis, as many of us know, you can make a diagnosis at the clinical level, and what I mean by that is that is at the field or at the bedside. So that's a clinical diagnosis. Then there are laboratory diagnoses that you can make, and that's typically looking at cerebral spinal fluid or at blood or at urine. And then there's what's known as a radiographic diagnosis. So my point here is that at this point in August 2017, our diagnosis is made at the clinical level. So it is open to subjectivity, okay? Or more subjective than at those other areas. So we don't have a specific test at this point. So it's important for us then to really be able to hone in and appreciate the signs and symptoms of a concussion. And they're divided into these 4 areas: physical, cognitive, emotional, and sleep. And I won't go into any more detail than that. Okay, so the next slide points out the challenges that we have with making this clinical diagnosis at the field or at the bedside. The athlete may not recognize that he or she has a concussion, so they're not able to provide you with a history. So that's a challenge. Symptoms may not appear until several hours or even days after the episode has taken place, and the athlete may not be forthcoming. I don't know how common this is in your junior high and in your high school and in your college, but that's been documented and appreciated in the pros. And it would certainly make sense to me that there's a lot on the line with these professional athletes as far as their income, their livelihood, and there's a lot at stake if a professional athlete or anybody ends up experiencing concussion. So the athlete may not be forthcoming with what he or she is experiencing. And we have to keep in mind that a concussion doesn't necessarily have to be associated with a loss of consciousness. So it's important to identify the concussion and to treat it conservatively. We now recognize that a player with a single concussion in a season is 3 to 6 times more likely to experience a second concussion versus a player that has not experienced a concussion during the season. And we think that that may be due to related impairments like impaired vision, visual field, reaction time, and balance. And there may be other impairments that are not as appreciated at this time. So here's something that I'm really proud and pleased with. So we now have in Iowa a law regarding sports related concussions. But there's some nuances to that I think that we really need to appreciate. It only addresses school sports activities. It does not address club activities. And so that's something that I think we need to keep in mind. And what it says here is that all the schools must distribute concussion information to the athletes and the parents or the caregivers prior to participation in the season or in the year, that all the coaches, officials, athletes, parents, providers must receive education regarding concussions, and that the child must be immediately removed from play if they show signs and symptoms suggestive of a concussion, and that they can't return to play until they have been cleared by a knowledgeable healthcare provider. But any healthcare provider can clear them. So that raises the challenge of not all healthcare providers are created equal with regards to understanding concussions. Not all healthcare providers have the same tools that are available to them, but they have to be cleared by a healthcare provider. And this law pertains to junior high and high school students. So Dr. McEvoy is going to talk much more extensively about REAP that we have incorporated into our management in Iowa. But I think there's some very important points to bring out. That we're using a multidisciplinary approach to this. So we're coming into this with a multiple education, multiple perspectives on looking at and managing these concussions. And we're going to talk a little bit later about an eye-opener that I've had with regards to the sensitivity of I think I do a pretty good neurological examination, but then when it's turned over to the concussion team where they really drill down on the patient's case, a lot of stuff is being exposed that did not show up in my neurological examination. So as I mentioned, Dr. McAvoy will be discussing this team approach or REAP and the team approach. So we'll be learning more about that. And what I want to focus in on is the medical component of managing the concussions. And I want to start right out in the field and then go to the ED, if we need to go to the ED, whether or not we need to get imaging at that point, and then how we systematically return them to academics and to sports. And then I want to talk just briefly about this concept of injury versus accident. Is a concussion an accident or is it an injury? That's an important point. And then let's talk a little bit about prevention. Okay, so the medical team is made up of several people. So it's a multidisciplinary team as well, and they basically have 5 roles and responsibilities. And that is to diagnose the concussion, to rule out more serious medical conditions, to provide rehabilitation to the child, to provide a graduated return to play and to academics, and then to provide final clearance. So what the medical team is keenly responsible for is assuring that that child and adolescent do not get back into sports before it is safe to do so. We want to take the pressure off of the coaches and off of the principals and off of the athletic trainers to return the player to their sports. So we do this by assuring that we won't sign off until it's time for, and that the child is safe to return to those sports. So let's go to the field. That's our first step. The focus in the field is to assure that the player is medically stable and that we have to assume that the individual has a spinal cord injury until it is ruled out. So we perform a sideline concussion assessment, medical examination to assess whether the concussion and the neck injury are suspected. We need to immediately remove the player if there's any suspicion of injury, and then we've got to decide whether or not we can triage, or excuse me, that we need to triage the child to the emergency department. So the choice at this point is, does the child just sit out? They can't go back to play that day. Is it okay for them to sit out, go home, and then return to their primary the next day for a serial evaluation? Or do we need to send them to the emergency department for further evaluation and intervention? What we're concerned about here is these signs and symptoms may be associated with a structural intracranial pathology. So the problem with a head bleed or severe edema is that it increases the volume in this rigid box, the brain, the skull. And if we increase the volume in the skull, we've got a certain amount of autoregulation that takes place. But at some point, as that volume increases, the intracranial pressure will go up. And if that intracranial pressure goes up, it can cause herniation that can lead to significant long-term impairments and disabilities, or even death. So some of the signs and symptoms of increased intracranial pressure and pathology are that the player is demonstrating repeat vomiting, or that there is unilateral pupil changes, or a worsening or a very severe headache. Seizures can occur after a head injury, and they're known as early onset seizures versus late onset seizure. An early onset seizure is a seizure that takes place between the event and 7 days. It doesn't have the long-term prognostication that a late onset seizure has. Unsteady gait or slurred speech is another indication for going to the ED. Weakness or numbness in the extremities, unusual behavior, or a Glasgow Coma scale that is less than 15. So these would be the indications. On the sideline, we've got the individual sitting out, and now do we need to send them to the emergency room for further evaluation of possible increased intracranial pressure and pathology. So I alluded to this very briefly before, but we need to keep in mind this risk of second impact syndrome. Keep in mind that the clinical features may resolve and disappear before the metabolic features disappear, okay? So the metabolic features may still be existing, but we're not appreciating them. So with this metabolic situation, you don't have the auto-regulation like you do prior to the concussion. So it's a rare condition in which a second concussion occurs before the brain has healed, and because of that, the brain loses its auto-regulation to regulate that pressure, and that can result in a herniation, severe injury, disability, and even death. So the take-home message here is, if in doubt, you sit them out. We've got to put safety ahead of everything. So we triage to the emergency department, and here's typically what we'll be doing in the emergency department. We have the option of doing a CAT scan. A CAT scan is quick nowadays. We can get a quick scan and look at the global elements of the brain. We don't need to use an MRI that would take longer to do that, but we're looking at, do we have significant increased intracranial, do we have a significant bleeding? Do we have significant swelling that may be contributing to the increased intracranial pressure? And we can pick that up on a CAT scan. We'll do serial neurological examinations, hydrate and monitor for emesis and early onset seizure activity. So those are the things that we can do by deciding to send the child to the emergency department. So then we have to decide whether or not we're going to do a CAT scan. And what we're in essence trying to do is we need to identify potentially life-threatening bleeds, fractures, or swelling in the brain. So we're taking it to the next step where we've got the clinical exam. It's suggestive of the concussion. We've got signs and symptoms suggestive of increased intracranial pressure / pathology, and now we want to drill it down and further appreciate that. But keep in mind, I think this is an important point, fewer than 10% of mild brain injuries have a finding on CAT scan. So these concussions are metabolic issues that are not picked up by the CAT scan. They may be picked up in the future, like by a PET scan, but a PET scan, we just don't have those around the country right now, okay? So this is, CAT scans are specific, but they're in essence, a big picture, global, general view of the brain, and they can be done quickly. Now, symptoms may worsen over time. I have, in my residency, very sad situation in which a child was hit in the head by a baseball, was fine, went to bed that night, and never ended up waking up. And what we ended up finding was that there was a slow epidural bleed that ended up resulting in increased volume, resulting in increased pressure, and this child ended up herniating. Although, when he had gotten off of the baseball field after being hit by the baseball in the temporal area, it hurt on the outside. He complained of a little bit of a headache, but he didn't show these signs and symptoms at that time. So the point is, these symptoms may worsen over a period of time. So our recommendation is not to clear a child to go back to their play and to their sports while they're in the emergency department. That occurs later on. So the next focus is on managing the acute issues related to the concussion. And there's really 5 major areas that we're looking at with regards to that. Managing the symptoms, preventing acute and chronic complications, monitoring, delivering medications. We tend to be very conservative with that. One of the important things is to reassure to the child, the adolescent, and the care providers that in most cases he or she is going to get better. It's going to take time, because these head injuries are so scary. On a sideline, if somebody injures and has a fracture to their arm, we say, wow, it's going to take 8 to 10 weeks to get better. And everybody in this room would say, yeah, it's going to take 8 to 10 weeks to get better. And we'll cast it and then we'll go on with the day, right? But if somebody has a concussion or a brain injury, we all get very, very scared. And we want instant results and we want instant healing to take place. But that isn't what happens with the body. It takes time for that healing process. The brain is the source of all of our dreams, our goals, our activities, guiding our behavior. So when that gets injured, we become very, very scared. And obviously we want instant results, instant recovery, but like we all know with the fracture, brain's no different. It takes time to heal and to recover. So that reassurance is absolutely important. And then we want to help the child and the adolescent to safely and successfully integrate back into their cognitive and their physical activities. So the question that comes up is, should we use rest or activity? It used to be that we would place an individual into a dark room and have them just rest. But that's not what the general consensus at this point is. That said, we don't really know the exact amount and duration of rest that we should that should be done. And so the key is, and I think this is an important point, is that we recommend increasing the activity gradually, but not crossing the line where it brings on the symptoms or worsens those symptoms. So it's a judgment call with this, so we need to be monitoring it on an ongoing basis. So as I mentioned before, and that we use a multidisciplinary team with multiple views and multiple tools. So Hannah Jepson and I are responsible for and Hannah's our nurse practitioner, and I'm responsible for doing the neurological examination on the multidisciplinary team. And what I am finding is that in many, many cases, the neuro exam is unremarkable. With the exception of the neuro exam is unremarkable, the history is remarkable, but the neuro exam is unremarkable. So it lacks the sensitivity that I used to think that a neuro exam had, because then the therapist, speech, OT, and occupational therapy will come in, and they will find oodles of symptoms as they're doing neurocognitive testing, vestibular testing, balance and coordination assessment, physical conditioning evaluations, linguistic assessment, and the list goes on and on. So I think we've got to recognize that if a provider is out in the community by him or herself that neuro exam is not adequate, in our opinion, to return that individual to play. The challenge, though, is in our state is that there are a lot of providers that are in rural areas. Not everybody has access to a multidisciplinary team. So I think that's going to be one of the next big pushes that we're going to have to figure out in our state using the REAP and other tools. How do we support these communities, these rural communities, in helping to safely and successfully return the kids to their academics and to their sports? So in this particular, the particular model that we're using right now that has been developed is there's physician, nurse practitioner services, therapy services, multi services that are provided, and then we'll provide services related to integrating the child back into the community. And I won't get into detail with regards to that. So the objective, one of the objectives is to return the child safely and successfully to their school, to provide them with guidance and recommendations. And here is the Berlin consensus on a graduated return to school. And it's got 4 components to it. And I won't get into any detail with regards to this, but that this is out here, and we use this a lot in our concussion clinic. And then the next objective is returning to play. And here again, we've got the Berlin consensus as well. Okay, the point that I wanted to also raise is that when we are returning the kids to their sports, they first need to be cleared academically before we return them to their sports. So they can only return to their competitive sports, that's going to be either practice or to their games, after the symptoms have resolved and they've been able to tolerate their academics without any accommodation. So academic comes first, and then we return them to their sports. And here is the Berlin consensus regarding the protocol for returning to their sports. So the next thing that comes up is, well, how many concussions is too many? And we don't know the answer to this. There are multiple factors that influence our decision making, but when push comes to shove, we really don't know how many concussions is too many before you say, you know what, I know you love wrestling, but you just can't do it anymore. But this comes up all the time. And then the issue that we're really concerned about, and it's really been highlighted in the AMA article, or that was published in the AMA, is this chronic traumatic encephalopathy. It's a neurodegenerative disease that is linked to repeated blows to the head. And as Dr. McKee says, it's no longer debatable whether or not there's a problem in football. There is a problem with repeated head injuries, repeated forces to the head. The problem is now becoming whether or not we should let our youngsters participate in this sport. That's a tough decision, because as Jeff said early on, sports is really, really important in all of our lives. This sport happens to be associated with chronic traumatic encephalopathy in some people. So let's talk about this concept of accident versus injury. So we all hear about a motor vehicle accident, right? An MVA, motor vehicle accident. I don't think there are motor vehicle accidents. There are motor vehicle crashes. If I am texting, if I go out and have too many beers, we all know that I'm going to be at increased risk of a motor vehicle crash. If I'm texting, I'm at increased 4 times risk of being involved in a motor vehicle crash. So this slide is to point out that accidents are random events. We can't study them. They just are. An injury has a cause and effect to it, and that we need to study the causes of these injuries. We now know that there is an association, I'm not getting any deeper than that, between football and CTE. That's an association. I don't know specifically, we haven't drilled it down to what the cause and effect, what the cause is at this point, okay? So we have to be careful with and being scientifically vigorous about that. If we have a cause, we can focus on the prevention, okay? So let's talk a little bit about that real quickly before we wrap up. So there are some myths regarding prevention. I used to think that, and it's interesting how it drifts into your mindset, because I'll tell you a thing that just happened 3 weeks ago with me. I used to think that if you put on a helmet, you were preventing the head injury. So 3 weeks ago, I like to mountain climb, and so I am really high up in Colorado, and I've just summited, and I am by myself. Okay, so that you can argue if that's good judgment or not. Okay, so but that's a different topic. So I say I'm coming down because there's lightning. It starts at about noon, and I'm coming down, and I said, oh boy, I need to get a helmet, right? So I go and I buy a climbing helmet. But you know what I was really thinking? Oh, I'm going to prevent the head injury if I have a climbing helmet on. No, I'm not going to prevent the head injury. I'm going to prevent the abrasion to the skull. But my head is still, so even somebody who studies this stuff, if he's not careful, will fall trap to the idea that a helmet will be protective. But what's the significance of that? If I believe that, then I am more willing to work my way down that mountain quicker because I'm protected, right? So we have to be careful about that. But a helmet will protect associated issues. For example, it can reduce superficial scalp injuries. A covered helmet doesn't have any protection, and in fact it may alter the lever arm of the neck and put the child or an adolescent at increased risk of a C-spine injury. Headbands have been limitedly researched and they're not encouraged or discouraged. It appears that mouth guards are helpful in preventing dental injuries, and face shields, while they don't change the risk of concussion, they can protect the face, the eyes, and the teeth. So what we have found is that what is protective is rule changes, restricting contact, head-to-head contact, for example, making sure that that we're using fair play rules, that we're changing body checking in hockey. So it appears that these rules, we're beginning to get evidence that these rules impact the risk of a concussion. The other thing is, a preventive measure is increasing access to recreational level sports. The idea being that rather than starting with a very, very competitive sport, which may be overwhelming the child and the adolescent, there are other options where they're participating in recreational sports. So the effect of education intervention for concussion appears to be time limited, and I've given a personal example of that. So what I've done, I just want to wrap up. What I've done is provided you with the characteristics of the concussion, highlighted the significance of them, identified the signs and symptoms, outlined a systematic approach, discussed how we go about evaluating and treating them, and an understanding of return to play and return to learning. Thank you very much.